and chairman of Palliative India, and he has done immense work in amending the NDPS Act in 2012, which has brought in a tremendous change in the opioid access and may change the opioid use in the coming years. And he has received Human Rights Watch Award in 2014, and he was awarded the prestigious Padma Shri in 2018. So there are so many things to explain, but we have reduced that into a few points. Thank you, sir, for coming for this session. Thank you so much, and over to you without wasting time. Sir, you're muted.
Hello, everybody. Namaste. After 51 participants, we have 43, right? I mean, is it okay? The background noise, the fan, is that giving a problem?
No, sir, it's very clear. Audio is clear.
Ladies and gentlemen, very happy to have you with us. I don't know if you realize it. Together, we are going to scoop out a huge burden of suffering from our country. If anybody is asking, will I be able to really do something? I would request you to change that sentence. Can I do it? Will I do it? Gets replaced by I will do it. There is no need for expensive equipment. No need for anything for any clinical practitioner here to practice palliative care along with your routine practice. You need only your heart and the little bit of knowledge that we will get. And it's not rocket science. Very easy things, nothing difficult to understand. So friends, I hope we can proceed with the assumption that all 40 participants here in this group have together taken a decision that we together will remove as much of suffering as possible from our country. Just trying to read some faces to see what the reactions are. Chetan, agreed. Okay, Chetan. Chetan is muted. Haripriya smile says yes. Swati, Sister Jency, we will do it, right? Sister Jency is already smiling. That smile I know says yes. No, seriously, you are here. The very fact that you are at this course indicates that you have the heart. A little bit of brain will go in from the course and we are all set. And remember one more thing. Once the course is over, we are not saying bye-bye. We should continue to work together. Sridevi, Sri Priya and all our team, and we have a separate division to work with people in any states together. We are sure that we will be here to work with you to introduce palliative care to wherever you are working. With that, can I start? If I had a lot of time, I would have asked you what you think is palliative care. I will not wait for your reaction, but I am still asking you. I'm asking everybody to answer to yourself. Jaya, Akhila, Arunraj, Kanmani, what answer to yourself, what is palliative care? You keep your answer within you and then we'll compare it with what I am going to say. Now, the fact that I am giving an answer doesn't mean that you're wrong. I'm not giving you the official definition of palliative care. The official WHO definition of palliative care is 20 years old, 2002. WHO itself felt the need to revise it. They actually handed it over to one organization, and eventually they were not happy with the definition offered. But many organizations have defined palliative care more recently. The definitions need to change, friends, because the concept itself is changing. Who knows who is the founder of the palliative care movement in the world? Would you like to type it out in the chat box? Who founded palliative care globally? Yes, Sharon, absolutely. Dame Cicely Saunders started it. Dame Cicely Saunders was a nurse who became a social worker. Then in her 30s, studied medicine, became a doctor. And when she started palliative care, it was only for terminal care of cancer patients. It was only for dying people with cancer. That is certainly not what palliative care is today. In 1986, when World Health Organization defined palliative care, they said when the disease is no longer responsive to curative treatment. And 16 years later, when they revised it, they went almost an about turn and said it must start early along with disease-specific treatment. So, what am I saying? The concept itself is changing. And I repeat, I am not giving an official definition. Nevertheless, I am giving you a definition. This definition, this is not a definition. This is a phrase which was used by the Lancet Commission on access to pain relief and palliative care in 2017, 5 years back. Serious health-related suffering. For all practical purposes, use that in your mind as your mission. Arun Raj, Roshni, Samiran, when you proceed to give palliative care to anybody or everybody, this is what we should try to do. If somebody is in serious health-related suffering, we should do what we can to alleviate it. This holds true for the persistent pain in the knee of your grandmother. It holds true for the person coming to the casualty with multiple fractures. It holds true for the post-operative patient squirming in pain. It holds true for cancer, HIV. It holds true for the person breathless from COPD. Any problem there?
No, sir.
Why, Samir, what explains the question on mark on your face? ये कैसे हो सकता है kind of question. But remember, this means that palliative care alone will not be enough for that person with the fracture or the post-operative patient. So palliative care will go along with treatment of the disease, hand in hand. That is palliative care. Okay, shall I stop there for any comment? You can unmute and ask or put it upon the chat box. Sri and Sri, if there is any comment coming up in the chat box, please call it out, shout
Yes.
out.
As of now, nothing, but we'll tell you. So Dr. Mohammed has just commented, very true,
Ready?
very true, whatever you have just shared. And there is a question from Dr. Epan asking, suffering has to be chronic. It's a question.
Dr. Epan, No, no, in capitals, underline 3 times. It is not even there in the WHO definition. It does not have to be chronic. Suffering is suffering. Thus,
So there is another.
Sonali, I am see. Thank you, Sue. Sonali, serious health-related suffering is defined in that document that I showed you. See, Sri and Sri, we will share this presentation with the participants. So
Yes,
in the
sir.
first slide, in the bottom, there is the Lancet Commission report, full text. You can it's available for free download. And if you look at it, it talks about serious health-related suffering. But then Neelima Devidas, Sri Devi, Sri Priya, please note, Neelima asks difficult questions. Make a note of Neelima Devadas. Neelima is dangerous. Neelima, seriously, you have answered your question in the second half of your question, Neelima. What is serious is not to be decided by you or I. If the person considered serious, it's to be treated. That does not mean that every post-operative patient you will register in a palliative care unit. Remember, the palliative care that I am talking about is not to be only to be practiced in isolated units. It is to be integrated to whatever you are doing every day. The surgeon who learns a bit of palliative care makes sure that post-operative pain is treated. So, Neelima, that was an excellent question and excellent answer also. That's to be decided by the patient who is experiencing it. And from Neelima's question, I will repeat this most important part of this. Palliative care is not only to be practiced in palliative care units or in Pallium India. Palliative care is something to be practiced by every clinician. The principles to be integrated into healthcare. We'll talk more about it. Jaya, we'll talk about it, but absolutely, Jaya, physical, psychological, social, and spiritual. Okay. The person with cancer of the cervix may not be in any pain now. Maybe quite okay, but her husband may have deserted her and she may have nothing to eat. I can't walk away, and Sridevi will not walk away from that. We will do what we can. In the place that you work, you may not be able to do everything that you want to do. We are not able to do whatever we want to do. We want to. That's the important thing. When we want to, we will see if there is an option. If we cannot do it, okay, I wish I could do it. Ashwin, again, another answer to be in capital letters, to be underlined. No, no, no. Palliative care is not only for terminally ill patients. Palliative care is for all patients, not only in cancer, at any stage of illness, if there is associated serious health-related suffering. Like this, in 2021 and 2022, 2 batches of oncologists underwent a course in palliative care. How many, Sri? Maybe together something like 60?
Yes, sir, 64.
So that means 60 oncologists in various parts of the country now understand palliative care and will try to integrate it into whatever that they do. And that's palliative care. Neelima, don't say sorry. You brought in I was only joking, Neelima. You brought in a very appropriate response. You raised an important issue and you gave the answer also. So sorry if I made you feel bad. I was joking. What about the person suffering from a mental illness? Mental illness can be extremely troublesome. We collaborate with the Department of Psychiatry in our medical college hospital. A group of psychiatrists and residents went through the palliative care course so that they can integrate palliative care into their work, and we can get their support when we need for consultation. Absolutely. We have treated several patients whose suffering was only because of mental illness. And especially when they are poor and from villages, they do not really access support from psychiatrists. So thank you everybody for the active participation. This is exactly what was required. Any question arising from my answers? Talking about suffering, remember that every year in our country, more than 26,000 people commit suicide because of health related reasons. Every year. And just think, for every person who has succeeded, how many would have tried and failed? And also remember this, India is among the top 12 countries in the world where people are subjected to catastrophic health expenditure. Whole families are destroyed. I have downstairs in our IP unit a person who is close to death. He is in pain, he is paralyzed because of spinal metastasis, but his greatest problem is his worry about the loan that he has taken for his daughter's wedding. And on top of that, he now had to do a CT scan and something else, borrowing money. That is more than 4% of our population. And palliative care is not only for terminal illness, but it's also for treatment of terminal illness. Right? Agreed? So what's your answer for this? Would you like to put up your answer in the chat box? Severe breathlessness in advanced cancer. Hardly able to breathe. Fingernails turning blue.
Sir, everyone is opting, most of them are opting home. One response about ICU, but otherwise everyone else telling about caring at home.
Look, why am I talking about him? Tomorrow, when my time comes, I'll have to die someday. I don't know what I'm going to die of. I have a 1 in 10 chance of getting cancer and dying of cancer. I have, if I live long enough, I have 1 in 8 chance of dying of dementia. Whatever it is. Where would I like to be? You ask me. Home, provided you can give me enough medical support. Listen, this man cannot breathe. Like this, he is breathing. What will he do staying at home? He should stay at home, provided, dear friends, you are able to give some support to them at their home. Monica, Teresa, Sean Mike, at least on the phone, if you are able to give some advice, support them, then it's okay. Without any support, home may be horrible for them. So home, I agree. Nothing like home for anyone. That's where I would like to be. If you support me. If not, I would rather be in a hospital room. But one thing I am sure of, I certainly will not want to be in an ICU. Hey, you give this a little thought. Rishikesh,
Yes, sir.
Rishikesh, Amrita, Teresa, give this a thought. Then on that day, those 2 days, my last 2 days, what will be the most important things for me? One, I should be free of that breathlessness. I should be able to uh, get relief from it. What else? Anybody? Anybody who is brave
Sir,
enough to think about your own
should,
thing? Yes.
should be near and dear ones.
Sorry.
Should be near and dear ones.
My
Near
dear
and
and
dear
dear
ones.
ones, my loving ones, my loved ones. I want to hang on to my son's hand.
Be
I
with
want a
family.
kiss on my cheek from my grandchild. Those are so very precious. Those are the most important things that are denied by IC units. You will put a tube in, right, in the ICU. Oh my God, into my throat. The so painful thing. And because I will try to pull it out, you will tie my hands and feet. This is the most horrendous infliction of torture. As a matter of fact, ladies and gentlemen, I guess we'll have one session on end of life, so I will not go into it. National Cancer Grid, the national collaborative of all cancer centers in the country, has together given a guideline that in advanced metastatic cancer, do not treat patients in the ICU. But that's what happens all the time. My friend Dr. Sankha Mitra, who does great work in the northeastern palliative cancer care, says the poor die in misery in India. Poor die in misery and neglect. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. So this is the National Cancer Grid guideline that I talked about. They say do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. So what about this man? How will you treat this man with severe breathlessness? Rushed into your emergency room, turning blue, intensely distressed. Now I am saying this, you all do work in hospitals, most of you. And there is a protocol. I know what will happen. They come into the ICU, immediately somebody will put a tube into the trachea, and if the obstruction is below the trachea, then they have to continue the obstruction and additional suffering in the tube. An endotracheal tube will help only if the obstruction is above this level. Okay. So what I will do, this is what we practice. Sri and I actually practice this. That patient will not be isolated. We won't say everybody out, everybody in. We'll try oxygen. How will you know if it is effective? Who wants to answer that question? If the obstruction is total, near total, the oxygen will not benefit. You can only give it here, you can't push it into the alveoli. How will you know if the oxygen is effective or not? If you try it for 10 minutes, actually 7 minutes are enough. If it improves the person's distress, the distress is better, it is effective. If it does not improve distress, you take it away. I won't even use a pulse oximeter for it. That makes no sense. What's our objective? He should feel better. We'll use corticosteroids. You know how? They reduce the peri-tumor edema. Are there any anesthetists or respiratory physicians in the group?
Yes, sir. I'm an anesthesiologist, sir.
Who is this?
Sir, I'm Dr. Vandana. I'm working
Doctor?
as professor. Dr. Vandana.
Vandana.
Yes.
So Vandana, you know that if the airway expands a little bit, a millimeter, flow increases 16 times,
Yes.
right?
Yes, sir.
1 millimeter more of airway means 16 times of airflow, 16 times improvement in airflow will occur. So when you give corticosteroids, reduce the edema around the tumor, it can cause remarkable benefits.
Yes, sir.
So unless there is bronchospasm on the other side or something, I will not use bronchodilators. I will not use any meaningless things. I will use corticosteroids. It will take time. And for the time to reduce the sensation of breathlessness, I will use morphine. Morphine for breathlessness, Vandana, is that acceptable? Vandana,
Yes, sir.
about a
Sir,
century
morphine.
and a half back, when I was appearing for my MD examination in anesthesiology, my examiner asked, tell me one contraindication for morphine, one absolute contraindication for morphine. And I said dyspnea. And the examiner said, very good. That was it at that time. That answer was correct. We believed that it was correct, but now we know. I'm not talking only as a palliative care physician. American Pulmonology Society, I hope I got the name wrong, have guidelines which says morphine is a drug of choice in management of breathlessness with COPD. It reduces the sensation of breathlessness. You do not give 15 milligrams IV. You give 2.5 milligrams orally, or you give 1 milligram IV. And the effect on the respiratory center will reduce the sensation of breathlessness. Person's breathing will become slower, slightly slower, and easier. Again, Vandana will understand that if there is obstruction, the harder you try to breathe, the more the pressure difference, the more the obstruction. So by easing the breathing, reduce the sensation of breathlessness, remarkable benefit is achieved. And remember, don't think it is illegal. According to the Supreme Court verdict, in the absence of a correctable factor in terminal illness, it is permissible to withhold artificial life support. There is no law or no ethical principle says that you have to intubate every dying person. These may not be usually understood by a lot of people. There are a lot of misconceptions about it, but all 40 of you and we together will try to change those misconceptions. Can you show that video, Sri?
Sure, sir.
The video will demonstrate what total pain is. It is my colleague, Ms. Smriti Rana, who is a psychologist by training, was giving a TEDx talk at the St. John's Medical College, Bengaluru. And we have taken a clip, which is only 6 minutes out of it. Thank you, Sri. Back to my screen. I hope that's visible.
Yes, sir.
So earlier, this question was raised. Whether palliative care is not only for physical problems, but also psychological problems. Here was a social issue, which was causing enormous suffering to the person. And this, again, is a concept that Dame Cicely Saunders talked about in the 1960s. She said social, emotional, and spiritual issues can worsen physical suffering, and vice versa. You can see that every circle is encroaching onto the other. See, that man's pain experience, pain is a physical and psychological, emotional experience that is worsened by his social and emotional issues. So, what we treat without any hesitation, in answer to the question that was raised in the beginning by Jaya. Jaya, I hope the question is answered. We should try to attend to all this. But then there may be questions in you. Sulabh and Akhila may be asking, hey, how can you do all that? And then to Sulabh and Akhila, I will say, you may not be able to do everything. We are only humans. We acknowledge the problem. We find out the problem. We do what we can. And at the end of the day, I'll go back home and tell myself, Rajagopal, you have done your best. That's all you can do. So we may not be able to do everything in these domains, but we try to. So friends, please answer this question for me.
It's time of diagnosis, sir.
Sorry, who said that? Can you please call out your name?
Sajid.
Sajid.
Yes.
This is the most correct answer among these. If that is what the WHO definition says, it should start at the time of diagnosis. I would say it should start even earlier, when the suffering starts. If the man is coming to you with agonizing chest pain, you have to treat it then. So it's not only for pain, it is not only for those with incurable illness, it is not only for dying people, not only for cancer, it is for all health-related suffering, and starting as early as possible along with treatment of the disease. That was not so at one time. The old definition said when the disease is no longer responsive to curative treatment. Now we know that disease modifying or potentially curative treatment will continue, and along with that palliative care will start. As the disease gets advanced, there will be more and more of palliative and supportive care, so that in the end, the disease modifying drugs may almost stop, except possibly for an occasional palliative radiation. And remember, friends, palliative care is not only for the patients. Mohammed, palliative care is not only for the patients.
No, sir. Sure. As
Then
you
who is
mentioned,
the-
as you mentioned,
Ah,
pain itself is different from different person. Perception of different person. So obviously, palliative care is not just only for pain, for every
no,
aspect.
sorry. My question was not clear. I am not asking whether palliative care is only for pain. I am asking, is palliative care only for the patients?
No,
And
sir. No, sir.
Yes,
Definitely not.
give the answer.
It is also for the patient's relatives as well.
Absolutely. And therefore, it should not stop with the death of the patient. It will continue as bereavement support, especially looking for people with abnormal, pathological, or complicated grief, supporting them, helping the family to come back to as close to normal as possible. On this day before yesterday, we had one of the monthly meetings. It's called Unarv or Awakening, which was a monthly meeting of people who have lost a loved one, where they all get together, exchange grief. That's only one of the ways of bereavement care. But important thing is palliative care starts when the suffering starts, goes along with disease treatment, and does not stop even with the death of the patient. Okay. And this, friends, is something you should remember. You are all, I mean, this presentation will come to you. When I am sure you will come across colleagues, hey, they will say, hey, Mohammed, Swati, are you crazy? Why are you talking about palliative care now? He has just come into the hospital. And then you will say, with respect, sir, or with respect, madam, the World Health Assembly in 2014 recommended that palliative care should be integrated into all health systems. In your tertiary care hospital, in a district hospital, and at the primary health center, across the continuum of care, from the beginning of the suffering to the end. Okay, World Health Assembly, by the way, is the decision-making body of World Health Organization. Very important statement for you to have. It's a tool that you can use. And finally, if you are to do this integration, you cannot do it alone. There must be, is there an oncologist in the group?
Yes, sir. We have around 10 oncologists.
Okay, Samiran. So when Samiran sees a patient in the OP, you, of course, you are looking at the scan and the findings, and then, but you are also looking at the face, acknowledging the suffering. You seem to be in pain, or you seem to be stressed. Just that question will bring out the fears, and the person may then ask, Doctor, am I dying? My daughter's wedding is 3 months from now. Will I be alive at that time? And when Samiran, you have facilitated that question and answered that question with compassion and competence, you have integrated palliative care into your practice. Of course, this to achieve integration of palliative care into all healthcare, palliative care units are important. I suppose Palliative India will still be important, even when Samiran does that, because there will be a small percentage of patients where Samiran will not be able to treat the pain or treat the breathlessness, may want to refer somebody to a palliative care unit. So this is the bulk of palliative care delivery by every clinician, and palliative care units are only for some. And remember, the best way of achieving this is with community engagement. Samiran, I don't know what kind of institution that you are working in. When you have some authority in your institution, you will ask people to come and help. In the Regional Cancer Center in Trivandrum, there are 3 NGOs, non-government organizations, giving care. One within the hospital, one providing home visits, and a third one looking after children with cancer and their families. So when you allow the community to come in, then only you will be really able to take care of psychological and social issues. For our work, the community volunteers and organizations are an important element. Any community medicine person here? Public health person?
Sir, I'm here. I'm Dr. Manoj. Yeah, sir. I'm Dr. Manoj. I'm MD Community Medicine, currently with WHO.
I could not hear. Would you hear?
Yes, we can hear. Dr.
Okay.
Manoj.
Sorry, doctor, you are not very audible.
Dr.
But
Manoj introduced, and Dr. Akhilas also raised her hand.
I am Dr. Manoj. I'm
Yes,
audible,
doctor.
sir.
Doctor, so even if others are not familiar with it, You must be very familiar with the Astana Declaration, which is an updation of the 1978 Alma Ata Declaration. By the way, Astana is the capital of Kazakhstan. That's where the world leaders, palliative, global health leaders got together and they made some statements. One, health for all has to be health with all. Engage with the community. Without support from the community, true healthcare cannot be given. This
Yes.
woman would have been bedridden for the rest of her life and would have died a horrible death if the local volunteers had not stepped in, made sure that she gets help. Dr. Sunil from our team went there to provide some painkillers, but essentially it was the volunteers who made sure that she walked and eventually learned to walk again. The Astana Declaration also says, reach people where they are when they need care. Haripriya, what kind of institution do you work in? Unmute, please.
Sir, I work in a maxillofacial center, sir. I'm a maxillofacial surgeon with
So you,
long
Haripriya,
yes, sir.
if you sit in your clinic, some people will reach you.
Yes.
For every one person who reaches Haripriya in her clinic, there will be 10 people who cannot reach you,
Yes.
either because they are too far away, or they don't have the money, or they don't have the transport. So just as Sunil reached them, that this woman and her family in their home, people need to have health care where they are, when they need it. You may not be able to do it immediately, Haripriya, I understand that.
Yes.
Do what you can in your clinic now, but at the back of your mind, remember, someday we must have a home visit program. I hope, friends, now we are doing this virtually. I hope someday you will come over, visit us, spend a few days with us, see what exactly we do and how we reach out to people in their homes and support them. I'm almost ready to end. You should know that though in India, less than 4% of the needy now have access to even basic pain relief. More than 96% of Indians do not even have access to basic health, pain management. But there are many positive things happening. In 2012, India created the National Program for Palliative Care. In 2014, India changed the law pertaining to opioid medicines. Making it easier to access. In 2017, the new national health policy included palliative care, at least at the primary level. And from 2019, medical students have most elements of palliative care in the medical curriculum. Certainly pain management, end of life care, attitude, ethics, and communication. From last year, nursing curriculum also includes palliative care. Friends, these are giant advances. I am glad you understood this course because 5 years from now, new graduates of MBBS will and BSc nursing will be graduating, having learned a lot of palliative care, and many of us may feel left out. So I'm glad you are doing this course and keeping abreast with the subject. I see that I have some 10 minutes left. I can come back to any other slides if you need to, but over the next 10 minutes, I'll answer any questions that you may have, or I'll try to answer your questions. Hey, Chetan, Chetan, are you from Sevagram? Chetan is not audible.
Yeah, he's there in the session. I think in the chat he has typed once that he's from Sevagram, I think.
Oh, I see. Chetan, also type up which department you are from. Community medicine or general internal medicine or where?
No, Dr. Chetan, we can't hear you. I think your microphone is not working. You are unmuted, but we can't hear you. Maybe you can just type it in the chat if possible.
Okay. See, I'll go through some of the comments that had come up earlier. Uh, uh, there was a question, Ashwin from Ashwin. Can we decide who does or does not require oxygen and ICU? Ashwin, if somebody is an advanced incurable disease or advanced metastatic cancer, as National Cancer Grid says, we should have it on the patient's notes. If the disease is not amenable to return to reasonable quality of life, that does not make sense. We should not provide ICU support. So only if there is a acutely reversible event in advanced cancer, it is done. The same holds true for certainly dementia and also for COPD or other conditions.
Sir, so my question, can you hear me, sir?
Yes, I can hear you.
Yeah, so I'm a medical oncologist. So I agree with what you say. I mean, I also don't encourage. But the thing is that any of these cancer patients terminally will develop a pneumonia, will develop an aspiration, and all those things. I mean, it is very difficult to convince patients. Sometimes they get very aggressive, saying you didn't take care of at that point of time. I would put them on a morphine infusion, keep them calm. If the patient is able to understand it, take a written consent, and then we palliate them. But the bulk of the patients don't agree to it. What is the stance on that? I don't agree with wasting an ICU bed for a patient whom I know is irreversible, who is moribund. But how do you manage such patients?
Ashwin, as the course goes on, I am sure we will be discussing shared decision making. Ashwin, suppose I am the patient and I may tell you, Dr. Ashwin, I don't care what you do, keep me alive. Actually, one patient told me that. She said, whatever happens, keep me alive till the 24th when my son will come home. I want him to see me alive. And we actually intubated her trachea and put her on a ventilator. That was her choice. It's a rare choice. But Ashwin, to take that decision intelligently, the conversation should start early. Ashwin, you are an oncologist. And therefore, after this course, one of the things that you will do, is to ask the patient, do you have any question? And or sometimes, do you want to know about the disease? Do you want to know about the prognosis? Do you know what is likely to follow this? Initiate the conversation early. When you are breathing like this, that's not the time when you can think intelligently. For both the patient and family, the discussion should start early. But Ashwin, having said all that, it is their choice. If they say, no, I want everything done to me, it has to happen. But the more you discuss, the less the need for that intervention will come out. Neelima, so does it almost mean that palliative care needs to be a way of life? Neelima, shall I say palliative care has to be a way of healthcare delivery? integrated into healthcare. But if you can apply the principle in everyday life, that is fantastic. Next time you go home to see your grandfather, just sit down with him and ask. Just ask, how are you, grandpa? The usual things, and then ask, grandpa, tell me the story of your life. Tell me about your childhood. And then, Neelima, you will discover that you never really understood your grandfather. So if you are saying, does it have an impact on everyday life? I would say yes. Chetan, I'm glad you have a palliative medicine department. And remember that integration is going to be not very easy. It will take time. And Haripriya, I have already answered your question. And Mohammed also has answered that question. All aspects of patient care, including counseling, if started early, acceptance is better. I totally agree. And Revati, true, it is not enough to answer initiate the discussion. We should also document it. Sonali asks, how do we make sure equity in pain medicine's accessibility? Women for labor and IUD insertion, people from minority are less likely to receive medicine for pain from pain from doctors than men. True. People from high socio-economic status. There I have a question. But Sonali, India is, I am very proud of being Indian, but I am not very proud of the fact that in India is one of the countries where loss of equity is worst. The disparities, the number of people living in poverty and starvation, these are horrendous. And Sonali, you are absolutely right. What you can do, Sonali, is to make the world a better place by, at least in your practice, somehow managing to get to give adequate care to the vulnerable. Today we will know we have a program where we identify people who are vulnerable for many reasons. You mentioned gender here, LGBTQI, geographical isolation, prisoners, people with disabilities, many inequities. We should try to give them better care. And suddenly, when you do, I'm sure many will learn from you and it will gradually increase. Amrita, yes, palliative care. And that's Amrita, that's not only my personal opinion. Remember, this is what World Health Assembly asked for. Integrate palliative care into all healthcare. Last few minutes and a couple of questions if Sridevi will permit.
Yes, sir. We can have a couple of minutes more.
Sir, I have a question.
Yes. Sonali.
Yeah, we had a patient who wanted to get an abortion, and it was really painful. So I asked them to ask the doctor for the pain meds, but they refused to get pain meds. And I know it can be very painful, but they said that I want to take unnecessary pills, but it was but in my opinion, it was not unnecessary at all. It was an extreme condition, and I know how painful it can be. But they just refuse and said they want to do it naturally. But even abortion is not natural, right? So why do people hesitate, especially women, hesitate in taking pain meds so much? I just don't understand this.
Sonali, you are in pain. because of that woman's suffering, and I have respect for that empathy that you are showing. So really, that is horrendous, but this is the reality in our country, that people are not given pain relief. People live and die in agony, even when the medicines are inexpensive and available. In many health centers have morphine, they don't use it. So this is horrendous, but Sonali, we will change it. You and I and everybody else will change it. I mean, like slowly. We have been at it for a quarter of a century. From 1%, maybe it has increased to 2 or 3% access to opioids. That's all. But there is nothing to be done except to continue to work at it, talk about it, write about it, and advocate for it. Okay, Sri, I think I'm everybody. I'm so very glad that you are also interactive. Thank you for the questions and comments, and it was a lively session. Thank you very much. I know you have a case presentation. I'm afraid I must leave you, but Sridevi, please continue.
Thank you very much, sir. Thank you very much, sir.
Thank you, sir, for the
Thank you, sir.
very informative, and it was amazing interacting with you.
Truly interactive.
Thank you, Dr. Mohammed. Thank you,
Thank you, sir.
Vandana. Bye.
Thank you, sir.
Thank you everyone for the wonderful discussion which happened over the chat. As I told, the more you interact, the more insights that will come up and more we learn from each other. So today, as a part of the program, as mentioned in the beginning, we have case presentations during every session, maybe except in 1 or 2 sessions. So today we'll present from our sides just to give an idea about how it works, and you will understand the structure. It's very simple, as I said before. And followed by that, we'll have discussion based on the case presentation. So today we'll present from our side. We have Dr. Grishma, who's a palliative care physician working with us in Palliative, India. So she'll present the case for today.
Good afternoon, all. Let us have case discussion. A 39-year-old male whose diagnosis is traumatic quadriplegia with stage 4 pressure sore on sacral region and left gluteal region. Presenting complaints are constipation for 2 days, bed sore over sacral region and gluteal region, moderate pain over the hip region, urinary leakage. History of illness. He had a history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic quadriplegia in August 2015. And he was admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region, stage 4, history of pain over the hip and wound side for more than 2 weeks. Pain on both sides of the hip. The score is 5/10 and intermittent burning type of pain. And at the wound side, he has 4/10 pain score, which is continuous and throbbing type of pain. Due to this, sometimes they keep the wound open and disturb sleeping pattern and decreased oral intake. On examination, he was conscious and oriented. Temperature is normal, pulse 82, respiratory rate 20, BP 120/70, and all the systems are within normal limits. And regarding pressure sore, there is warmth and tenderness, and exudate was present, tunneling present. It is irregular in shape and was foul smelling. And regarding investigation, hemoglobin 10, total count 34,000, polymorphs 80, lymphocytes 18, eosinophils 2, platelet 1.6, serum creatinine 0.9, serum sodium 132, and potassium 4. And psychosocial aspects, he was a 39-year-old unmarried man who was living along with his mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual labor and was the breadwinner of his family. Now his mother is a manual laborer and she has to take care of him. Now the main source of income is from mother's daily wages, her pension, and some of his friends also support him and have taken rupees 1.5 lakhs from private finance bank for the treatment purpose. And he was a devout Christian, now able to not able to go to church, and this makes him very sad. He communicates through cell phone and he says to his mother like, I don't think I can work, so please don't spend money over my treatment. And his main concerns are pressure sore, pain, and financial problems. Summary: 39-year-old man with traumatic quadriparesis with bed sore present over sacral and left gluteal region, stage 4, with pain over the hip region. And discussion points are: do we need to provide palliative care for this patient? What are the problems faced by this patient? And what all can be done for this patient and his mother? Thank you.
Thank you, Dr. Grishma. And we would like to hear from you all. What do you think about? We already had a discussion on for whom we should give palliative care at what stage of illness. So this is a very a different scenario where the young male became had an injury and became bedridden and totally dependent on the family. So I would like to hear from you in the chat, or you can unmute yourself. Do you think is there a role for palliative care? And what do you think we can do for this patient and his family? And what all, based on what we had a discussion with Dr. Raj, what do you think he might be going through in his life, and what all can be done? Thank you, everyone. I can see the chats, Dr. Amrita, Pratima, Ashwin, Dr. Jaya, Dr. Monica.
Doctor, can
yes,
I speak?
Yes, Dr. Manoj, please.
Yeah, definitely palliative care approach is most important in this patient because he is very young. And moreover, the productive life is hampered, and he's more worried about his mother, and as well as the financial outcome is bad. So he's the breadwinner maybe for the family. So the financial concern can be like something can be done from the side of NGOs or something like that to at least see that the mother will not have any issues with her. She can be given some alternatives like whatever is known to her, some small scale type of setup, something for her daily going up. And for his health as such, I think it is in the hands of the healthcare providers and even the other family members to give the positive approach towards his upcoming future. That can be through positive counseling approach. And as he has got good, he's go to church, but he's not able to go to church. Something like prayers can be done for his at his home itself, because he was mentioned as he was as a Christian. So this sort of things can be done, and further some other points may be added by others. Thank you.
Thank you, Dr. Manoj, for sharing your thoughts. Yes, Dr. Monica has mentioned, yes, we have to give palliative care. And Dr. Haripriya, yes, as Dr. Manoj mentioned and many others, that mother needs psychological support. Would you like to speak a few words about it? Like, why do you think and how do you want to give that psychological support? If you can unmute and talk. That will be nice. Or you can.
The mother needs to be strong because she's strong. Still, he's trying to put her away, make her understand that all these things are useless. She should not give in to such things. So the mother also needs a psychological support along with the patient to be strong for both herself and for the son. That's what I feel.
Thank you, Dr. Haripriya, for sharing. Yes, and many of you might have read a lot of evidence on the caregiver burden and the caregiver distress, and which is unaddressed. When we go to a patient's house, we usually talk to the patient because we can see multitude of problems that he's on, like along with the physical problems of bed sores and unable to move, bowel bladder issues. He also has other psychological and social and spiritual issues. So the whole focus may go to the patient, and we keep telling the family that do this, give this medication 3 times a day, feed him this, feed him that. So they tend to be overwhelmed because they have to take care of themselves as well as the patient also. So in the past, we have seen many patients, caregivers, especially when the female caregivers, they tend to stop their medication, even if they're diabetic or hypertensive. They don't have time to go to a hospital to check their blood sugar or the blood pressure. So because they can't leave this patient and go somewhere. For example, this mother, she can't take a day off from work and she can't go for her own treatment. So they tend to have more problems after a period of time than the patient. Then there is no one else to support. So it's very important to include caregivers' physical condition as well. The moment you go to a house or start seeing a patient, it is a good practice to ask the caregiver about their comorbidities, whether they are on something. At least when you have the counseling sessions, it is very important to have a separate session for the caregivers, because what they can't talk in front of the patient about their burden, right? In our culture, we feel a little guilty telling that I am overburdened, I have not slept for months. Especially mothers or wives, we feel so guilty to admit that we are burdened. We are supposed to take care of the patient for years, or whichever time they need. So it's very important to have a separate conversation with the mother or the primary caregiver to understand what burden they are going through. Thank you so much for bringing in that point. I think many others have, Dr. Roshni has also suggested palliative care for the patient and the mother. Yes, Dr. Chetan, yes, he had physical, emotional, spiritual, as well as the psychosocial problems. And Dr. Amrita has pointed out 2 problems specifically. One is wound and psychosocial issues. So coming to the wound, how do you recommend to take care of his wound? Who will take care of the wound and where? How?
Good afternoon, ma'am. I'm Dr. Vandana. Can I speak a few words
Yes,
on the
ma'am.
wound care?
Please, please.
Thank you, ma'am. So, regarding the wound, since it is present on the back of the patient, it is not possible for the patient himself to take care of the wound. It is in the sacral area. So, we cannot expect the patient to take care of it. He definitely needs someone else to do the dressing and the wound care. Now, in this kind of scenario where finances play a lot of role, taking the patient to the hospital is not a practically possible, or keeping the patient there also may not be very affordable to them. So what needs to be done is the patient needs to be taken to a hospital once, where the dressing or whatever is done, and that is shown to the attender or the caregiver, and she should be explained that this is how it is to be done. You have to care for it in this way, and she should be given the medicines at the reasonable affordable cost, so that she can continue to care for the wound at home itself, and then she can just follow it up whenever required. So that would be a more practical approach, where she need not skip her work, but at the same time take proper care of the wound. I hope I am right, ma'am. If I'm
Yes,
correct.
thank you so much, Dr. Vandana. Very valid point, because this wound needs care every day. They can't take this patient or similar kind of patients every day to a hospital to get the wound dressing done, which happens very often in many places. Like they pay money for a nurse to come home every day and get them dressed, or they take the patients to the clinic. So what Dr. Vandana was mentioning was a very feasible or a sustainable way of taking care of the wound, because the wound is going to be there for pretty prolonged period of time. Unless you are you don't have financial constraints, maybe you can go for a grafting and a surgical correction, but many times in many settings it is not really possible because of the financial constraints and difficulty in access to all these services. So for treatment to be sustainable, the caregiver has to be empowered with a balance that we cannot burden the caregiver a lot, but she has to, as you mentioned, as much as possible, if it is a head and neck cancer wound, we tell them to do the dressing on their own. But if it is a sacral wound, we can't tell the patient to go ahead with the dressing. But yes, caregiver is one option to train. Yes, Dr. Dhanwandi, right? Am I pronouncing it right? You've raised your hand.
Yes, ma'am.
Yes,
Ma'am,
please.
I wanted to ask if it's labeled as palliative care, are we allowed to do something as definitive as doing a skin grafting and covering the ulcer site, or does that not come within the purview? Because that essentially is, I mean, then involves maybe a vac dressing after that or something. Is all of that allowed in palliative care, or is it not considered?
Yeah, I think anything that brings in the quality of life, which is adding on to the quality of life. If they get, so if suppose for this patient, I can't offer an expensive treatment, that is going to become a bigger burden for the family, because now they know that there is a treatment available. Because we are poor, we can't get it. So this will keep disturbing them generally. They keep telling, we hear that very often, that doctor told this can be healed, but because we are poor, we can't do the surgery, so I have to suffer. I wish I had that money to get cured. So these kind of thoughts are there. But if something is just feasible, if that is possible, yes, definitely yes. If that is, so we wish all of our patients get all this, because we do get a lot of patients who are paraplegic with huge bed sores who are very young, and we wish we could provide definitive treatment for all of them. But the financial burden is huge, taking them to a hospital, and you know how far it costs for a surgical correction, and after that they have to stay there for a hospital. So yes, if it is feasible, that's the best possible way. It is not denied, because these patients have a life limiting illness, doesn't mean that we cannot give a surgical correction or intervention. If it is going to improve the quality of life, definitely it should be given. Yes, Dr. Amrita.
Hello, everyone. I just wanted to share on the same thing that in our institution, we have a very plastic surgeon who does reconstructive surgeries on these patients. And yes, there have been cases where after the grafting and after these surgical procedures, the patient, they might have passed away. But then the joy that has brought to the family or even to the patient itself before they passed away has been, it's just, that's something that we are proud of, I think. So I think it's a good thing if it's available and if it's funded and if the funds are available. Yeah, thank you.
Yeah, thank you for sharing that, Dr. Amrita. Yes, if it is feasible, that's the best possible way, because as you said, having a wound, huge wound on your body is not something that, it's a constant reminder of your debility or the chances of getting infection. People are really scared to see that wound. Many a times we have seen young patients going on to depression, thinking that I have an unhealing, non-healing ulcer or a wound on my body. That's quite depressing for the patient as well as for the family. But if it is funded and if it is available and it is feasible, that's the best way to go about it. But otherwise, on a larger scale, we empower the caregivers to take care of this wound at home as cheap as possible, which is more sustainable. Then it's a high chance that they do that when it is cheaper and can be done at home. I can see other comments like to link with a social worker or some charitable trust in his locality for any social support. Thank you, Dr. Shun. Yes, that's one way of connecting. If the mother is overburdened, you can always engage the community volunteer, or if you have a bunch of students who are willing to help a patient in their locality, we can always teach them at least once a week. If you can go there and dress the wound, the mother can have a peaceful day. At least once a week. So that's something we need to get from the community. That kind of support may not be practical all the time, but that's something that we should explore. Yes, Dr. Dhanwandi, please.
I'm sorry to interrupt.
No
I
problem,
want
please.
to ask on the other end of the spectrum. I practice in Mumbai in a private hospital, and we have what I struggle with another set of problems. Funds are not an issue. So the relatives are willing to spend. Relatives are generally people living abroad. the mother, paraplegic mother or bedridden mother, stroke patient might be lying at home with 2 attendants, 3 attendants, whatever. And there is no limit to the amount of surgical interventions done on that person. So in a similar scenario of a quadriplegic person, barring the age, now this boy is a young boy, but suppose it's an older person, I always struggle with whether we should tell them at some point you don't need, bed sores are eventually the way they will go out, right? They will have a bed sore, it will get infected, sepsis, and the patient will pass away. So when funds are not an issue, when funds are an issue, that becomes a limiting factor. But when funds are not an issue, is it ethically correct to keep suggesting surgical intervention one after the other? And at what point do you call this, put a stop to it, because eventually this is going to recur?
Thank you for asking that. And this is what I told, learning from each other, because this is a very opposite side of what we have been talking. I'd like to listen from other participants. What do you think? Money is not an issue. There is a bed sore, recurring bed sore. So should we keep doing interventions? Yeah, Dr. Kanmani has also asked the kind of similar question. The possibility of recurrent sores is high. So how it is going to be helpful?
We
I think, may I?
Yes, yes, doctor. Yes, doctor, please.
I think it is not suggestive to do repeated surgeries on the patient, because surgery is again that comes into the mind of the patient. Post surgery also, he is not been recovered, he or she is having the same thing, and the wound is not being healed much. So it is better we go on a positive approach from the first itself, like at least like once or twice we can do the surgery, but later on along with the surgery, I think it is better to inform the family members as well as the patient that the outcome would be at the end not 100%.
Thank you, Dr. Manoj, for sharing that. Dr. Naveen, yes, please.
Yes, ma'am. On the same note again, because I practice in a part of underdeveloped semi-urban Uttar Pradesh, so where the spectrum is entirely different. We see a lot of patients who are in need of palliative program, oral malignancies, and patients with disabling illnesses who do not have a support system, where the family struggles to make 2 square meals in a day. So considering the diversity of the haves and the have-nots, this in my opinion, I was thinking is that the essence is what is the need or how beneficial is the treatment for the patient, any patient, let it be a bed sore or an illness. The treatment or the cure of the illness must not end up being more difficult than enduring the illness itself. Like for a patient, in a very sick patient, if doing the surgery, I'm a surgeon, doing the surgery is not going to improve his quality of life, or rather the possible morbidity or complications from the surgery and the stress of going under for the surgery is worse than him being in his current state, then I think that really makes us question whether does he need the surgery or is it actually indicated for him.
Totally agree, Dr. Naveen, totally agree. Because many a times, so we have both examples here where people who have undergone surgery on the mercy of some surgeons who are willing to take up patients for free. So we send them for surgery. So there are patients who got a very good, improvement in quality of life after that, even patients who are depressed. But post-surgery time was, as you said, was a lot of caregiver burden, and we ourselves have to take care of the patient because the caregivers were unable to manage this post-surgical wound in a home setting. So that is one thing that we face, but it has improved the quality of life of patient. But on the other end, that happens only maybe 1 in 10 patients, not 1 in 10 even, maybe 1 in 100. So other 99 we manage conservatively. And there is a good example where the caregivers were able to take care of the wound and it has come out really, really well, where it will be monitored by the team at least once a month or so over a video call. So both ways, yes, but as you said, we need to have a balance between whether it is going to give a more burden to the patient and the family, or are we actually improving the quality of life. That discussion has to happen with the family, with the team members. And whenever I talk about bed sores, I strongly believe that prevention is completely possible. I am not worried about the recurrence or anything. It's completely preventable. So that is something that we focus here. We empower the community, the nurses a lot about prevention of bed sores. It's not that easy. We can keep telling them, change the position, change that, this bed, that bed, but it is completely preventable. So that's where we should focus on. As said in the palliative care definition in the beginning, prevention of suffering is something that we should. We have an entire session on bed sores. Maybe that is time when where we'll be discussing more about it, and we have a session on ethical dilemmas where the same thing will be discussed again, when to tell them to stop, how to put an end to the unnecessary interventions, and what is the risk and benefit. We'll have more discussion on that in the coming session. But yes, it's not that easy to decide many a times. Thank you, Dr. Naveen, for bringing in that point. Yeah, there is another comment. The guilt of not doing anything from the attender's side has to be addressed specifically when they can afford multiple procedures. Yeah, so I think it's essentially a balance between when to, as Dr. Dhanwandi mentioned, we can't keep going. It's a balance between when to start, when not to do. It's very important to understand when not to, or de-prescribing or de-escalating the treatments that we give. Dr. Vandana, please.
Yes, ma'am, I would like to make a point here that I think in these cases, the patient also should be given a choice. What exactly the patient wants. Does the patient want? It's about the patient doesn't want a surgery. I don't think even if you have loads of money, you should force the patient for the sake that you might get a better outcome. So I think after multiple surgeries, the patient might be so psychologically upset with, if it is good result, the patient might himself say, yes, I'll undergo the surgery because it has given me good results. So in these cases, I think the patient is the best person who can make a decision whether he wants this kind of treatment or not.
Yes, a very valid point, Dr. Vandana. I think Dr. Dhanwandi would agree that even if the patient doesn't want, sometimes the caregivers decide to go ahead with the treatment and they just say, don't listen to the patient. We know what we are doing. Like, we need that. Yes, we will be discussing all these aspects in detail during many sessions in communication, as well as in medical ethics, as well as in prevention of bed sores. But yes, it's not very easy from both sides. For us, it is not very easy to give an intervention, but on the other side, sometimes it's very difficult to stop an intervention being given. Thank you so much, everyone, for the valuable interaction. Yes, Dr. Nilima, I'll try to send, if possible, a few handouts. Maybe if possible, I'll just ask my nurses to send a PowerPoint if that helps, or a video of a previous session if possible. So that's something which I can do. Just send a reminder email to or a message in the WhatsApp group. I'll try to do that. Thank you so much, all the participants. This has been wonderful interaction, and we are really looking forward to these kind of interactions in the coming sessions also, so that the learning will be really great. And please start sending your case presentations, because when you are on the session, it's easier to send and beforehand. Otherwise, it becomes difficult later on. We all have a busy schedule, so just start sending it after today's session. Now you have an idea like what we expect from the. It's very simple. It won't take much time from your work. It's just 5 slides and just bring in a lot of discussion kind of question. Please don't repeat the same question. That happens with every batch. Everyone asks, does this patient need palliative care? Now we know who needs palliative care. So bring in your discussion points. What do you want to discuss in the group, and what are your questions? That will be learning for us also. Thank you so much, everyone. Before winding up, over to Sri Priya.
Thank you, Dr. Sridevi. The feedbacks, the general comments in the chat is overwhelming. Everyone thanking for the good, wonderful sessions. Yes, with an assurance that all the sessions are going to be very interactive and very informative. Please don't forget to leave your feedbacks, because at the end, it is what makes us improve ourselves. So please do take out some time and provide feedbacks. And please do feel free to reach out to us in case of any queries in connection with the course. With that note, this is Sri Priya along with Dr. Sridevi Vaidya and Dr. Grishma signing off from the Tip Psycho Hub. See you in the next session. Till then, everyone, take care. Bye-bye.